Thank you. So good evening, ladies and gentlemen. I am Dr. Neha Jain, and I welcome you all on behalf of Emcure Pharmaceuticals to another exciting evening of no thrombosis. In our journey of last 7 months together, this small initiative of Emcure has evolved into a learning platform for the neurologists across the country, where we discuss, deliberate some unique and interesting cases and become wiser in stroke management. We are privileged and honored to have with us the stalwarts in neurology in the country, guiding us in this initiative of ours. Ladies and gentlemen, I now take pride in welcoming our esteemed faculty members for the events today. I first welcome our course director, Professor U.K. Mishra sir. Sir is the director and HOD of Neurosciences Department at Apollo Medic Super Specialty Hospital. Sir founded the Department of Neurology at SGPGI Lucknow in 1987 and was also the department head of neurology at SGPGI Lucknow. Sir is the director, executive registrar, dean, and in charge of research and at SGPGI. Sir is trained in clinical neurophysiology in Italy, Sweden, and he was also a WHO fellow in the USA. Sir has made original contributions in the field of stroke, epilepsy, GBS, and neurotoxicology. Sir has over 462 articles published in various reputed national and international journals. I now take pride in welcoming our moderators for the event today. Our first moderator is Dr. Jayant Roy, sir. Sir is the Director of Stroke Program and Senior Consultant of Department of Neurology at Institute of Neurosciences, Calcutta. Sir is a certified neurosonologist accredited by American Society of Neuroimaging in 2005. Sir is recipient of 2005 American Society of Neuroimaging William M. McKinney Award for writing the best manuscript based on clinical research in neurosonology. Sir is a member of editorial board of Journal of Stroke Medicine, member of Global Executive Committee member, Society of Neurosonology India, and member of Educational Committee of Joint World Stroke Congress of Hyderabad chapter in 2016. I now welcome and introduce our second moderator for the event today. Our second moderator is Dr. A.O. Saroja ma'am. Dr. Saroja is a professor and head of Department of Neurology at Jawaharlal Nehru Medical College, KLE Academy of Higher Education and Research, Belagavi, Karnataka. Ma'am brings with herself over 25 years of experience in the field of neurology. Ma'am holds special interest in cognitive neurology, cerebrovascular disorders, epilepsy, and neuroinfection. Ma'am is an active member of prestigious bodies like Indian Academy of Neurology, Indian Stroke Association, Indian Epilepsy Association, and various other eminent bodies. Ma'am has presented papers and posters in various national and international forums and has also written chapters for various Indian textbooks of neurology. I now welcome and introduce our key speakers for the program today. Our first speaker is Dr. Sonia Tamke. Dr. Sonia is a consultant neurologist and epileptologist at Kaveri Hospital, Bengaluru. Dr. Sonia holds special interest in epilepsy, neuroinflammatory disorders, headache, and facial pain. She has obtained certifications in various EEG programs, for example, the National Epilepsy Surgery Support Activity Network EEG certification, EEG training certificate by American Epilepsy Society, and a certificate by Mayo Clinic USA in headache management. She is also one of the only 30 candidates chosen from the world for the prestigious EEG Diagnosis and Management of Epilepsy program held by the International League Against Epilepsy Academy. I now welcome and introduce our second speaker, Dr. T. Karthik Reddy. Dr. Karthik Reddy is a consultant neurologist at Karthik Poly Neurocare, Mehboob. He has done his DNB neurology from the prestigious Institute KIMS from Secunderabad, and he has also presented papers in various national and state level conferences. He'll be presenting an exciting case of window period stroke. With this, I would now request our course director, Dr. U.K. Mishra sir, to give us a brief opening remarks, please.
Thank you. And good evening. It's a great opportunity to meet just after the festival of Holi. I don't know how much you celebrate, but in North India, it's a very important festival. We had 2 days of vacation, and now we are going back to work from tomorrow. Uh, I was thinking, these meetings of case discussions started because there was COVID and there was no way to interact and teach and learn, and therefore this virtual program came in, and it was very successful and useful. But now in our region and overall, the COVID seems to be receding, and now will be the question that what will be the situation, or what will be the fate of these meetings, because the trigger to initiate this program will be now vanishing, and we will be normalizing. But then I was thinking, that it's a very cost effective, simple and convenient method. Once in a month you interact and meet new people, or and you see exciting cases. Some of them you learn, some of them you see the problems which. So I'm very optimistic. And even though it's very good that after this festival COVID will not be there, but I'm very optimistic that this program will be there. But it will be there depending on the response of the consumers. I mean, the people who want to learn and the people who want to teach. So ultimately, it all boils down to a reciprocal relationship between the presenters and the listeners. So I'm very hopeful, and I hope it will be a new. It's actually new year for us. Indian New Year is starting now, and I think in New Year this program will continue to blossom. Thank you very much. Dr. Saroja, good evening. I know Dr. Saroja personally, so a special good evening to Dr. Saroja. Thank you. Yeah.
Ma'am is there, I think some technical issue maybe. Sir, so should we go ahead with our first case present?
Yes.
Saroja ma'am just replied. Yeah. Dr. Sonia, I would request you to please share your screen.
Yeah, I will. Good evening, everyone. I thank the course director, moderators, and Emcure Pharma for giving me this opportunity to share this case. So I'm presenting a case of a young gentleman that we received in our ER. He had no comorbidities. He presented with history of burning sensation on right side of face 3 hours prior to the presentation. That is since he woke up at 2:30 a.m. in the night, and slurring of speech since 2.5 hours, and weakness of left side of face, upper and lower limb since 2 hours. So coming to history of presenting illness, this 29 years old gentleman with no comorbidities, non-smoker, no alcohol intake, no recent vaccination or COVID. He woke up in the middle of the night at 2:30 a.m. and he was having burning of right side of the face. Subsequently, he became a little restless, and then he started developing the slurring of speech. And over next 1 hour, he developed weakness of left upper and lower limb. There was no significant past or family history, as has been mentioned prior. There were no other comorbidities. So our first thoughts were stroke in evolution, because this was a very young patient. We also wanted to rule out other stroke mimics. His GCS was 15/15. Vitals were stable. BP that we have to keep in mind whenever we are considering a patient of stroke. It was 128/80, and sugar was 122 milligram. He had gaze paresis to right, left facial weakness, and left upper limb and lower limb power was 0. NIHSS score was coming to across 12 out of 42. So our considerations were wake up stroke, stroke with stroke in evolution, stroke in young. We were considering lots of things at the time of presentation. Stroke mimics also we wanted to rule out because this was a very young patient with no comorbidities. So as a protocol for wake-up stroke, we shifted him immediately to MRI. And as we can see, we saw anterior pontine diffusion restricted lesion on the right side, which was correlating with his deficits. And there were no flare changes. So he was well within the window period for this thrombolysis. MR angiogram that we did was suggestive of 50% stenosis or eccentric stenosis of the basilar artery. So this is the timeline. He woke up at 2:30 a.m. with right side facial burning. 3 a.m. he developed dysarthria. 4 a.m. he developed left upper and lower limb weakness. Entry to ER was 5:40 a.m. because young husband and wife, they were clueless what to do, so they called friends, and then that's how they came a little late. After the MRI and after receiving the consent, we thrombolyzed him at just the time 15 minutes prior to the 4.5 hours cutoff, 6:45 a.m. Subsequently, he was stabilized and shifted to a stroke monitoring unit. We thrombolized him with injection Tenectase 0.25 mg per kg. Coming to the basilar artery that I showed, there was 50% stenosis. Interventional neurosurgeons and our team, we were contemplating whether it is chronic stenosis, whether it is acute eccentric thrombosis, whether we should go ahead with DSA and thrombectomy right away, or whether he should be electively undergo stenting for the basilar artery stenosis. Patient was under close monitoring. 3 hours post thrombolysis, patient started worsening in the form that he started developing, his BP started shooting, he started developing vomiting, nystagmus, ataxia of the right hand. So with this, because he was thrombolized, we wanted to rule out IC bleed, so he was shifted for emergent CT scan, which did not show any bleed. However, it showed this still eccentric kind of filling defect in the basilar artery. So we took decision for DSA and thrombectomy at 10 a.m. 7.5 hours from the time of onset of stroke. However, there were only young wife was there. She was not so well educated. There were a lot of phone calls involved, a lot of opinions involved. So they finally gave consent for DSA and thrombectomy at 11:30 a.m. And so this was the DSA before procedure. Sorry, there is a skull base overlap. However, this did show the same findings as this did show the same finding. There was a filling defect in the basilar artery. So he with the solitaire stent retrieval, he underwent a thrombectomy of the basilar artery. And this is the post thrombectomy DSA, which showed the basilar artery thrombus was removed, which just showed a small filling defect in the PCA, distal PCA. However, this despite multiple trials, the surgeons could not take that out. So he was, after DSA, he was shifted back to stroke unit. His left upper limb and lower limb weakness did persist. However, his ataxia and nystagmus had settled. And this was 24 hours post DSA, which showed well established infarct in the right hemipons, and there was a tiny cerebellar infarct. However, PCA territory, there was no infarct that could be seen. Patient gradually improved after acute care. By 7 days, he was discharged to a rehabilitation center. recent 3 months follow-up, a patient has come and he's a MRS score 0. He's a mechanical engineer. He's perfect with no deficit, left upper limb minimal distal weakness, but he's independent. He's able to walk. He's able to talk. And there are absolutely no deficits. So this was this is what is our case, and this is our team. Here, what we found interesting was in the basilar artery thrombosis. There is, even though the ASA guidelines say that thrombolysis has to precede thrombectomy. However, after discussing with many of our friends, there is a thing called snowstorming effect in basilar artery thrombosis, because basilar artery gives a lot of perforators, it gives lots of branches. So whenever thrombolytic agent is given, the thrombus, it breaks open and it starts occluding multiple branches, distal branches, so which is apparently called snowstorming effect. However, I could not find this effect in any of the literature, but my stroke friends who are doing specifically working in stroke did come across with this explanation, snowstorming effect in basilar artery thrombosis. I would like to learn from the course director, Mishra sir, and also from the moderators about this effect. Thank you.
Dr. Sonia.
Yes, sir.
Excellent case. I congratulate for this, bringing up this very interesting case, and some bold step you have taken.
Yes.
Salvage the patient. It's commendable. Now, a couple of things. One is, do you have the picture of the basilar artery prior to the thrombectomy? Was it a partial occlusion or?
It was a partial occlusion, sir. Eccentric partial occlusion.
Okay, with some forward flow.
Yes, sir, with some.
That was seen in the CT angio as well, right?
Yes, sir. Yes, sir.
Okay, so what made you to decide about thrombectomy in a partial occlusion? Suppose you gave Tenectase already.
Yes.
And I mean, do you think that this thrombectomy helped him, because there was some forward flow? So definitely that was probably helping. So on the top of the thrombolysis, was thrombectomy helpful, and what made you think like that?
Yes, sir. As I mentioned, because it was 50% stenosis, we were also contemplating whether to actually go ahead with the thrombectomy initially. But however, post thrombolysis, he started worsening in front of our eyes. His eyes started oscillating like this. So that is when we were sure that whether his cerebellar is getting involved. He also started vomiting. His BP started shooting. So he was still stroke in evolution at that time. So we did not want to miss out further worsening of this young patient. So for that, we did take a call to go ahead with DS, our team, basically our team. We decided to go ahead with DSA. And if there was a occlusion which was feasible for thrombectomy, our decision was to do that. And our interventional neurosurgeons were able to do that. And he did improve. His nystagmus did settle. As I can see, the first MRI showed diffusion restriction only in the pons, whereas 24 hours post scan showed a cerebellar infarct as well. Probably he would have gone, superior cerebellar artery might have been involved. The pica was about to get involved. So probably that is what we saved by taking decision for thrombectomy.
Right. I think as you also mentioned at the end of your talk that there is a snowstorm effect. Well, whatever you call it snowstorm, it is definitely known for basilar, because once you open the basilar, the clots can go into the distal circulations, including PCA or sometimes SCA, or if it is a down below, sometimes ICA. Yes. So it depends on where the clots go. It's a splinter effect. I call them splinter effect, whatever. So now, in my opinion, what might have happened, that if you look at the infarct, it is from the right hemipons, right?
Yes, sir. Yes, sir.
It's right hemipons and probably some part of middle cerebellar peduncle, if I recall the image properly. So the circumferentials, the long circumferentials are probably occluded.
Okay.
So the thrombectomy probably helped to remove the clot which is occluding the circumferential.
Okay.
It's not actually an occlusion per se.
Yes.
It was a thrombus partially occluding, but it's actually occluding the circumferential. So the good thing you did is you removed that.
Yes.
So the circumferential got the circulation back and the patient improved. So in the hindsight, I think that was a very bold decision and correct decisions to remove that clot. And this is exactly why people are not comfortable to stent the basilar in case of an acute situation. Suppose you have a very tight basilar and you have a thrombus. Some people, after a thrombectomy, if they find this tight basilar, they put a stent. Some people are against it. They just do a angioplasty and leave it there, rather than doing a stenting and occluding some circumferentials in the basilar. So I think this is how it helped. And the clot which went upstairs to the PCA, probably in the proximal P2, which could have been sometimes laced with a little bit of intra-arterial TPA. Because reaching there with a stent is sometimes not easy, depending on the anatomy, but a little bit of TPA sometimes helps. Because the TPA was already on board.
Yes.
I do not know whether interventionists have tried already the TPA, but sometimes it helps.
Okay.
But it was an excellent case and very good outcome. Congratulations.
Thank you.
Sonia, nice. It was a good case. I just want to see what we do is we have tried these things, and unfortunately, in some of these patients, we've had massive bleeds.
Yes.
When we ask for thrombectomy, this was always a difficult situation in posterior circulation folks. I was just interested in knowing whether after the thrombectomy, before the thrombectomy, you did MRI or the CT scan repeat?
The CT angio, madam. It was CT, plain CT with CT angio.
Looking at the cerebellar infarct, whatever you said, that the patient worsened, probably it happened even before the thrombectomy. Patient could have had already a right cerebellar infarct,
yes,
which would have produced that weakness and vomiting.
Yes.
And that's what I thought. And that what was the final cause of stroke in this man?
Madam, we have done extensive evaluation. He's one, we had to put in one of those cryptogenic stroke. For some reason, in past 3 months in our hospital, we have seen strokes from 22 to 35 years very frequently. And they have been extensively evaluated with cardiac evaluation, Holter, prothrombotic workup. All the evaluation in him came negative. Only homocysteine was 32 micromoles per ml, but all other tests were negative. However, homocysteine alone as such is not such a high risk factor for stroke, as per some literature. Though it is debated, we did not find cause for stroke in him. He's on dual antiplatelets, and he's under continuous BP and other sugar monitoring.
Discharge MRS?
Discharge MRS was, discharge MRS was around 1. He was needing support to walk. And subsequently, he was discharged to a rehabilitation center. And
does he require rehabilitation?
Sorry, madam?
With MRS1, why does he require rehabilitation?
Because he still had weakness in the left leg. It was around 3. The power was around 3.
If he gets support, needs support, then it's not 1.
It's not 1. It has to be
2. Yes.
It should be 3 at least.
2.
Okay. Nice presentation. Thank you.
Thank you.
Sir, Mr. Sir, any comments?
Very nice case. First interesting thing was that, this patient wakes up with burning on the face. So this was probably a stroke, post-stroke pain, which begins with the stroke. This is a very rare presentation of post-stroke pain, that it begins with the stroke. What happened to that pain? Did it disappear or it was persisting?
It disappeared, ma'am. It disappeared, sir. A day to almost.
Sometime, it is very intractable and troublesome. And in these patients, homocysteine, when you don't find anything, we give importance to homocysteine, and then we check up for B12 and folic acid. And sometimes you find these two being the culprit, then it is very easy to treat them. So we just look at sometimes it's difficult, people give B complex injections and tablets, so the levels are not very reliable. But if it is not, and you find B12 levels low, then it is a very, very rewarding. I mean, at least you got something to treat. And we continue. And I've got some patients, who have developed venous thrombosis and even arterial thrombosis and have found to be low B12. Then, actually, I took up a project with ICMR with the proposal that, the vegetarians would have low B12 and will have homocysteine and will have more stroke. So this was the proposition with which I went and did a study for 3 years. Of course, I did not find it, because of the, the statistical data was not supportive. But, in once in a while, we get this thing. And this third thing, in such cases, I look at the CV junction, and I'm sure it must not be okay. But quite often you find this odd posterior circulation stroke, and you find CV junction anomaly. And sometimes they may not be very significant clinically, but you find one, and then we find. So these are few odd things, but this is a very good case. And I think it was I can imagine that the patient coming with the post, severe stroke, and then he is worsening, and his eyes are showing nystagmus and vomitings, and, to take up the decision to do the angio and then go on to, suction. This is all very, very brave, and all is well which ends well. So yes. My congratulations, and very educated case. Thank you.
Not allowed.
We move on to the next case, sir.
Sure.
Yes.
Yeah.
Yes.
Dr. Karthik, please share your screen.
Good evening, everyone. Today I'm presenting a
You can make a full mode.
yes.
You can right bottom, you can see, sir. Just right to that. Right. Another, yes, there's the icon.
Yeah. This is about a patient which I've seen 3 days back. Is 72 years old. He's from Mahbub Nagar. He presented with sudden weakness of the right upper limb and lower limb with slurring of speech since 1 hour 30 minutes. He was apparently normal before that, and he was able to do all activities independently. Suddenly, he noticed weakness in the right upper limb and lower limb in the form of he has difficulty in holding glass of water, and he had difficulty in raising the arm, and he has difficulty in standing himself. He needed support to stand. 15 minutes later, the patient noticed difficulties to speak with deviation of angle of mouth to the left side. However, he was able to understand the words spoken by others and could identify the objects. He has no significant history, past history, not a diabetic, not a hypertensive, no history of any coronary artery disease. An examination was a febrile and pulse rate was 80 per minute regular, and his BP was 170/90 in the left upper limb. So initial NIHS score was 9, and immediately was shifted to the MRI with MR angiogram, and it showed there is small area of diffusion restriction in the left coronary radiator with corresponding area of ADC mismatch. And his MR angiography was normal, and GRE showed no blooming. As patient was within window period, so we thrombolized with Tenectase after excluding the exclusion criteria. After thrombolysis, 24 hours post thrombolysis, his NH score improved to is dropped by 7 points. Significant improvement was there, and we ordered for repeat CT. In his repeat CT, we found that he had small hemorrhage in the left thalamus along with the left caudate nucleus. But it is asymptomatic as patient improved significantly. So the question, I have a doubt whether to start antiplatelets in these patients. And either investigations for normal, sugars for normal is checked immediately on admission. And ECG showed LVH pattern, studio echo showed concentric LVH, and creatinine was normal. So this is the at time of discharge.
Let's Nadu Tada. Nadu. Ikadibo. Malikadira. Nadu. Maladu. చేతులేపు పైకి. ఓకే. కూర్చో. కూర్చో ఇక.
So after 24 hours of thrombolysis, sir, he improved, and we discharged him yesterday. So my question to the moderator, sir, whether to start antiplatelets in this patient with that low dose antiplatelets, because there is a
I want to ask one question.
Yes.
You've done MRI before the thrombolysis. Were
Yes,
there
ma'am.
any microbleeds?
No bleed. GRE was done, but there is no blooming.
Can you show us 1 second, Dr. Kirti?
Yes.
These images.
1 second. This was the MRs, GRE sequence.
Okay. And go back to the DWI and ADC.
That's
Okay. All right. And what was the NIH at the baseline?
9, sir. 9. It was 9. After 24 hours, it was 2.
Yeah. I was just thinking that because these are not small bleeds. The left thalamic bleed is not very small. So it will be difficult to start immediately antiplatelet drugs, although he has had a stroke. And then have you repeated the scan only 24 hours or later also you have the scan?
No, madam, only 24 hours. Immediately.
No, you're waiting just 2-3 days. Today is the 3rd day for him.
Yes, ma'am.
I was thinking that probably this patient also has amyloid angiopathy, wherein if they have post thrombolysis, they could have bleed. That's a little common to have. That's one thing. But with this, it's not a very small bleed in the left thalamus. To give dual antiplatelet will be, of course, out of question. And what is the risk factor you said?
Hypertension. De novo hypertension, madam. ECG showed LVH and echo also showed concentric LVH. But he never figured out.
And this thing, so we'll have to wait for some time. I don't know. That's my opinion, because this is not one bleed. There is also in the caudate and left thalamus. Does he have anywhere else the extra cerebral bleed? Upper GI?
No.
It's only in
it's only this.
Yeah. So maybe I would wait to start antiplatelet drugs soon after this, because of looking at 2 bleeds there. And I don't know, I will ask this the other people, the senior people who would probably be this thing. But I would reserve giving a dual antiplatelet therapy in this gentleman. And I would also look at probably amyloid angiopathy, which has made him bleed, I think. And what is the blood pressure? Did he have any hypertension post thrombolysis? Did he have any elevated blood pressures which can also cause bleed?
Yes, but during his stay, it was always 170, 180 BP was.
No, that may not cause. Did he have, accelerated hypertension and then uncontrolled within the 24 hours, which can wait for him?
No, it is always below 180 only, madam. Never crossed 180.
But what about his coagulation profile? They are normal?
Normal only, madam. All other parameter blood tests are normal only.
Most things are normal.
Yes.
So, yeah. I think, yes, a small dose of aspirin maybe, but the guidelines, usually we wait for a week or so. So, I don't know, we'll ask the other people also. That is my opinion.
Thank you.
Well, Dr. Saroja, I think I agree with you. I think before you discuss about the antiplatelets, if we look at the stroke, the initial DWI and ADC, the mechanism looks like it's a perforated territory. So it's a small vessel disease. And the bleed happened again in the perforated territories, one in the thalamus and one in the caudate. So these two are not very usual location of amyloid bleed. Had it been in the cortical areas, I would have been more inclined to amyloid bleed. They are typical location of the hypertensive bleeds, if we get hypertension related bleeds. Since this is a post-TPA, so, and second point is, since this is a small vessel disease, where double antiplatelet is not indicated. So if we at all give antiplatelet in a small vessel disease, I think single antiplatelet is enough. And in this bleed, of course, we have to wait. And the urgency of giving an antiplatelet is not that high in small vessel disease in comparison to atherosclerotic large vessel disease. So, as Dr. Saroja pointed, I would rather wait for 2 full weeks for this bleed to settle down. And then I will start a single antiplatelet, a low dose aspirin. And of course, the most important is to take care of the hypertension, because controlling hypertension is probably more protective in small vessel disease to prevent second stroke rather than giving aspirin itself. So concentrate on BP control, wait for 2 weeks, repeat the scan, the bleed should resolve by then. Then we'll think about giving.
Yes, I agree. I think that's a valid.
Sir, your opinion?
Very interesting, I mean, these two bleeds are typical hypertensive bleeds. One is the thalamic, other is the caudate. They are typical positions for hypertensive bleed. And interestingly, when we look at the type of hemorrhage, a type of hypertension which produces these bleeds, it has been found that majority of patients have moderate hypertension. What this patient has was 170 by 100 or 95 millimeters of mercury. So this is okay. What you had was a small bleed, small infarct, and that is why we do a CT scan after 24 hours to see if there is a hemorrhage or not. And incidentally, these hemorrhages came up after thrombolysis. These are small hemorrhages. They are not compressing or damaging the internal capsule, and therefore the patient has no hemiplegia. And in spite of these two hemorrhages, he's okay. I'm sure whether he had headache or not, I don't know.
No.
And very interestingly, we made a classification of thalamic hemorrhage. I mean, just for our own self, we call them type A and type B. And type A, which doesn't affect the internal capsule, and type B, affects the internal capsule. So the one which affects the internal capsule leads to hemiplegia and poor prognosis. So this one is going to, but probably it has not damaged the internal capsule, and therefore the patient is doing well. And caudate hemorrhage anyway has good prognosis. So the patient was lucky that he had very, very small hemorrhages, but only it tells us that these are hypertensive hemorrhages, and we should be more careful with the control of blood pressure. Check for other causes of multiple bleeds, is coagulopathy and all must have been checked, I'm sure. But hypertension control is the most important. And I agree, antiplatelets are not the primary thing to begin with. And later on, we can give it to prevent the cardiac stroke and ischemic stroke later on, but that is not an emergency. But very interesting. I mean, this only tells us that we must repeat a CT scan after 24 hours of giving Tenectase, because otherwise we would have missed it. Thank you very much for a very interesting case.
Thanks.
Right. Is there any question waiting? Neha?
There is one question, sir. In fact, there are two questions. One is that what should be the period or range of hours for thrombolysis? Maybe they want to ask about the window period, and the other is 2-week period okay to resolve hemorrhage completely?
Well, I can take that question. First of all, the period range for hours for thrombolysis for IVTPA, we use this 4.5 hours window. And if you look at the evidence for alteplase, this 3 and 4.5 hours, there are some changes in the indications as per the guidelines, but we use them uniformly in our practice. So for the Tenectase, it is the same kind of thing. But if you look at the regulations and the labeling in India, there is a little difference, and it is approved in first 3 hours for acute ischemic stroke, but we do use them for 4.5 hours equally. So 4.5 hours is the standard for IVTPA window for eligible patients. And secondly, this resolution of hemorrhage and starting antiplatelet or anticoagulation, whatever, we use this timeline as a case-to-case basis. There is no single guideline. It is, in one way, the urgency of starting antithrombotic therapy, and other way, the risk of bleed or increase in the bleed. So in this case, as Sir has mentioned also, that starting antiplatelet is not super urgent. So that's why we can safely wait. I told about 2 weeks from my perspective, but if you wait for 3 weeks, again, probably you are right. So there is no rush in this particular case to wait to see the blood dissolve, and you can start antiplatelet, but BP control is the number one goal. Had it been a large vessel disease with a stroke and the patient has got a small bleed, I would have probably started antiplatelet a little earlier. The same applies to a cardioembolic stroke where they have a high CHA2DS2-VASc risk or a thrombus sitting there in the heart. So we all rather start early anticoagulations, ignoring a very small bleed because the risk of thrombosis outweighs the bleed. So it's a case-to-case basis, and we take a judgment based on the scenario.
Sir, I have one question.
Yes.
This is not relevant to the cases that we discussed today. In cases of stroke, if we see acute stroke, if we see 100% occlusion of internal carotid, extracranial internal carotid artery, what is the ideal management for such patients?
Well, there are two things. One is, if you see there is an IC occlusion at the neck, then, and if they have a complete internal, complete circle of Willis, they should not have a stroke, first of all. They can have a stroke if there is a tandem occlusion. If you have a clot here and if you have a clot lodged upstairs. So in that case, if you have a tandem occlusions, then the approaches are twofold. One is, question is, what is the mechanism of this extracranial carotid disease? There are two things usually happen. One is atherosclerotic disease. On the top of that, there is an occlusion and there is a tandem occlusions. And second possibility usually you do see is the dissection. These are the two scenarios we commonly encounter. So some people, they try to cross over it and go upstairs and do a mechanical thrombectomy. And to cross it, some people prefer an angioplasty just to make a room so that they can go up and do the procedure and come back. Some people stent up front this neck and then go upstairs. It all depends on the scenario, the choice of the interventionist, their skill set. So these are the things to be taken into consideration, keeping in mind that you have to open the MCA. Some people even, they fail to cross the guidewire through this. This can also happen. So some people, if they have a ECOM, good ECOM, they went to the contralateral side through the ECOM, reached MCA, and tried to remove the clot or gave intraarterial thrombolytics. So these are all disparate scenarios. But the standard approach commonly is through this, take care of this either by angioplasty and stenting and take care of the MCA clot. And while coming back, either you leave that after an angioplasty or put a stent. So there are two schools. And if you look at the ESCAPE trial, which is a mechanical thrombectomy trial, there are 12 or 13 cases. They encountered this, and the outcome of those patients who had a neck intervention before MCA was not different than patients who had only M1 occlusions. So it's again the skill set of the interventionist, the scenario, and how they handle it.
Most often what we see is a very long segment occlusion. Then it becomes difficult to put a stent for them. Absolutely. This is clinically what we see often in our practice is a very long segment occlusion. That is when, stenting will not help. And that's where you have problems. Most of these patients who come for CABG, and you see that they have a very long segment arterial, ICA occlusion. So that is when you have a problem. And this is, I think, almost remains a controversial thing, whether to go for CABG first or carotid endarterectomy first. So this is another topic of debate. You are called by the cardiologist. They have asymptomatic, but they have a long segment occlusion. And you're worried about the perioperative strokes. So this is one more thing, and that is not stentable because it's a very long segment. So it's difficult in those situations.
That's right. And sometimes they even go to the petrous part. So which is again very difficult by endarterectomy also to handle that. So those cases are really difficult, and it's really, you do not know. I mean, 80% or more stenosis, even they are asymptomatic, they increase the perioperative stroke risk by almost 10%. So they are a little bit difficult cases. I agree with you.
Sir, I also have a question.
Yes.
Sir, we discussed about the snowstorm phenomena today, in Dr. Sonia's case. So I think on the KT's platform, we've discussed all sorts of cases, but this is one phenomenon which we have discussed for the first time. And as Dr. Sonia also mentioned, I also haven't read about it in the literature per se. So I just, for the interest of our audience also, sir, what makes it peculiar to basilar artery? Is it the anatomy of the artery, or it is seen in other arterial occlusions as well? And another thing is that how do you suspect it? And then be careful, how does the management in such kind of a phenomena differs than the management otherwise in a case of stroke?
Let Sonia answer that.
No, so I have tried to search extensively in the literature. I couldn't find. Maybe it's because the perforators are so many. It has vast area of supply. Whereas if it is M1 occlusion, it will only go to the distal. If the embolus, after we thrombolize, the embolus will only go to the distal. Whereas in the basilar artery, if the fragments are formed, there's so many places it can go. So I think that is the only.
Well, I think in this era of advanced multimodal imaging, we have understood stroke mechanism a little bit better than earlier years, and that helped us to decipher many those stroke syndromes, the clinical syndromes. For example, your capsular warning syndrome, or pontine warning syndrome, which was a clinical construct at one point of time. Now we understand that this capsular warning syndrome is not just because of a small vessel disease. And we have also perforators from M1, which is coming down to the capsular area. So suppose you have a clot, which is sitting at the proximal M1 on the top of your perforator, and some blood is trickling down, and you are getting an improvement, and at the next moment it is blocked. this is the same thing might have happened in your case when it is blocking a perforator. Now, the perforators, circumferentials, they are more rich in the basilar. This is the reason the basilar have this transverse arteries which can be occluded, or the longitudinal when they go into the PCA territories and beyond. So this is how the basilar is little bit different than the other anterocirculation arteries, and also difficult to diagnose upfront clinically unless you are very suspicious about a basilar stroke. So if the neurologist who sees a patient in the emergency room and doesn't care about to take a proper history might miss a basilar stroke, because there are myriads of presentations like a seizure, sometimes like just a drowsiness, just a vertigo kind of thing. So yes, basilar is sometimes very elusive. You have to be basilar minded to pick up a basilar stroke, and the management sometimes is challenging, but again, rewarding. Even in a late window, if you do a basilar thrombectomy or into some kind of interventions, it's very rewarding. So chase a basilar. That's the dictum.
Thank you, sir. I think that's probably the catch line for today. Chase the basilar. That's thank you very much, sir. So probably we have come to the end of the session today. Any more comments, Professor Mishra, sir, Saroja ma'am? Any more comments?
In Sonia's cases, it's not that just because you thrombolized, you expect the basilar artery to open. In large vessel strokes, only 30% of them can open, and it's always like, not that everybody will worsen and need thrombectomy. And sometimes we have burnt our fingers even with thrombectomy, because you open the vessel and then there's already a very well-established stroke and there is a bleed, and we have lost patients. So just because of thrombolize, that doesn't protect this person from getting completely to have the vessel opened up.
Yes.
Professor Mishra, sir?
I think both the cases have been very, very educative and very
So
interesting.
this is what we.
What is most important is the variation in anatomy and individual variability. For example, we all know that the capsule maintains the homunculus organization, but when you do it, when you follow with the patients, the homunculus is not respected. Similarly, we will see a similar anatomical location or anatomical lesion does not have a similarity with the other patients. So these variations are very, very individual, depend on the vascular anatomy, collaterals, and systemic factors. So I think it all makes it very interesting. So even two cases, what a fascinating, two hemorrhages coming up and asymptomatic. And had you not done the CT scan, you would not have even known it. So this is the beauty of clinical medicine. Every case teaches you new things and raises new questions, answers a little, but raises more questions. So it's fascinating to see each case. And so I never think we'll ever get bored of these cases, Thank you very much.
Thank you. When we thrombolize, it's not that we don't expect that real result that what is depicted. And every time it's like that, you thrombolize, at least you're sure that it's not going to worsen. But the improvement, we don't see the dramatic improvement in all the patients. Sure. Even though you thrombolize them within 3 hours, or even if the door to needle time is less, we don't see this like how people.
It's like everything day-to-day life. It is like this only. Sometimes you get unexpected rewards, and sometimes you get this rewards. This morning we thrombolized a patient, beautiful result. Leg weakness improved, and he is very happy. Everything hunky dory. But the next case may not be that good. So this is what makes the clinical medicine so interesting. And it is so nice to discuss these cases with such learned audience, and especially Jayanta and Saroja. And every time new people come in to present. So thank you very much.
Thank you very much.
Before we finish, I just have a very small comment. So what Sir was telling, And I just recall from my training days, my supervisor used to tell me that if you have 4 or 5 consecutive very successful thrombolysis, then be careful. Your law of average will catch up next time. Be careful about the bleed next time. So this is the game of thrombolysis. And second is what Dr. Saroja was telling, the stroke mechanism in Sonia's case. This is also my observation, because we have been also seeing a good number of young stroke patients who has got apparently no such big so-called vascular risk factors. And what I am suspecting, I do not have enough data to now tell, but I probed, and I find that binge drinking is probably coming up as one of the risk factors in young stroke, especially hypertensive surge and bleed. And sometimes some people came up with maybe some transient atrial fibrillation, I don't know, but they came up with an ischemic stroke, and we found no mechanism found. Everything was clean later. So and most of them, they deny the history of alcohol intake, especially binge drinking. So we have to be careful about binge drinking in younger generations. And I don't know what other people might tell me.
No, during COVID, we saw that all the young people who were presented with either venous or arterial, they had very massive strokes. Not that they may be having asymptomatic disease, but we saw in the last 2 years massive venous infarcts. Within 2 hours, the patient goes into malignant cerebral infarction. I don't know if this is the experience that you people are seeing, but I have around 1,000 patients of CVT whom I have followed up in the last 20 years. So what we saw this year is that young people coming with venous infarcts, within 2 hours, they have to go for, decompression. And it was and young strokes, arterial and venous, they were very bad during the COVID time.
For some reason, venous stroke is not that high in this part of the country. I do not see too many. And in last 2 months, I have seen 2 patients, 3 patients, and one needed decompression, and the other patient, he needed mechanical thrombectomy, thrombosuction, and the other patient managed well with heparin, LMWH. But yes, COVID has definitely increased in the incidence of young strokes in last 2 years. And I do not know whether they are also drinking during this lockdown period.
No, we have had no such factors, only COVID, and then there is no symptomatic COVID. We saw it was very difficult for us. We see around 100 patients of CVT per year. So we have a large burden of venous strokes, but we saw that malignant venous infarction, malignant arterial infarction during COVID time, post-vaccinal, and we don't know whether they had it or not, because it is too late for us to prove that they had it. They had COVID.
Absolutely.
Thanks very much. Good night, I think.
Good night. Very, very important messages being given through this forum. The trends in everything, I would say, be it MI, be it stroke, the trends of things impacting the most productive segment of our country, the trends indicating towards post-COVID complications. I think we all need to be very, very careful. Thank you very much, Professor Mishra, sir, Dr. Jayanti Roy, and Saroja ma'am, for your wonderful insights and time to make this platform even richer. And we had great discussions today. Thank you very much, Dr. Sonia and Dr. Karthik, for bringing 2 excellent cases to the panel today. With this, we stop here. We'll meet again next month with another exciting evening of no thrombosis. Thank you very much. Good night, everyone.
Thank you. Good night.
Bye.
Dr. Mishra, sir, good night.
Good night, sir.
Good night.